We are down to the final four. So the final four lectures for 1242. We have two lectures on reproduction. Today we'll look at the male reproductive system and STIs, and then on Wednesday we will cover the female reproductive system. Next week there will be two lectures on lymphatic system, definitely on that last push of lecture material. So the male reproductive system is fairly straightforward. Its purpose is to produce sperm and deliver sperm. So we're going to cover, we'll actually start with the scrotum. So this skin and muscle sac that holds the testes. The testes are the main male organ of reproduction. So it's where the gametes or the sperm are going to be produced. Then we'll go through the system of ducts. So collecting the sperm, maturing the sperm, and transporting the sperm. And then we will also talk about the accessory glands because they produce very important secretions that without these secretions and without their components in the right proportions, then sperm are either immotile or they won't make it into the female reproductive tract or they won't have enough energy to survive. So all of this works together to produce viable sperm. So the first structure we're going to talk about is the scrotum. So the scrotum is a sac of skin and superficial fascia. The purpose of the scrotum, because it seems a little precarious, right? Why would you put like your fatherhood on the outside of your body? It seems maybe a little, not the brightest, but the reason being is that sperm production requires a temperature that is 3 degrees lower than core temperature. So by hanging the testes outside of the body, it lowers the body temperature, but the scrotum is also very good at keeping a constant temperature. So when the temperature changes, so when it gets colder, there are two muscles that are going to pull the testes up closer to the body and keep them warm. So one layer is smooth muscle, and that is the dartus muscle. And it is also the muscle that wrinkles the scrotal skin. Then there are larger, these are also kind of supportive structures called the cremaster muscles, and these are skeletal muscle. So the purpose of the scrotum is to maintain a temperature that is 3 degrees lower than core body temperature, 3 degrees Celsius. And this is required for sperm production. There are two muscles, one that is smooth muscle, that's the dartus muscle, and then the other one is the cremaster muscles. And these are stronger and more substantial because they also help maintain structure. And these are made of skeletal muscle. So this is the scrotum. So there's a superficial fascia, then that smooth muscle of the dartus muscle, and then cremaster muscles, which are much more substantial because they are going to be part of this spermatic cord as well. And they help maintain structure. So the cremaster muscles are skeletal muscle and they're more substantial. Then we're going to talk about the testes. So each testis is surrounded by two tunics, two layers. There is an inner layer that forms a fibrous capsule. So on the diagram, it's what makes the testes look white if we had the actual realistic picture. And then the second tunic is external to that, and it is called the tunica vaginalis, and it's from the peritoneum. So the important thing is that the testes are surrounded by two thick, fibrous tunics that form a capsule to encapsulate each one. There are septa that divide each testis into about 250 lobules, and each lobule will contain between 1 and 4 coiled seminiferous tubules. There are myoid cells. We're going to talk about, there are actually 4 important cell types in the testis. So we'll talk about each of those 4 types. One of those is the myoid cell, which are smooth muscle-like cells. That's where that myo comes from. And these will help to squeeze out the sperm, and then testicular fluids, which will nourish the sperm. Sperm is produced in the seminiferous tubules. We'll go through that process to what's called a straight tubule. That's the end of the seminiferous tubules, because these are very coiled, and then they straighten out to a compartment called the rete testes, to the efferent ductules, and then to the epididymis. The epididymis is we're going to talk about it in greater detail as well, but it is made up of a head, a body, and a tail. Sperm will spend at least 20 days in the tail section maturing. Okay. There's also the spermatic cord here that is going to contain the testicular artery, the ductus or vas deferens. We'll talk about that when we talk about the duct system. Autonomic nerve fibers. We'll talk about parasympathetic, the important role of the parasympathetic system and the sympathetic system. It's one of the very few examples where the parasympathetic and sympathetic nerve system work together. Normally they're opposing and regulating like a seesaw, but in the male reproductive system, they are synergistic. And then we also have this venous plexus that is part of the spermatic cord. So the spermatic cord, oftentimes when you have structures that need to be kind of encased in a fibrous connective tissue and transported through, in this case, through that abdominal wall, you'll often, pretty much every time, you'll find an artery, a vein, and this type it's a venous plexus, and then nerve fibers. And then we also throw the vas deferens in there as well. So you should know the components of the spermatic cord. Trying to think if you'll need to know the pathway of sperm production, but probably not all of these structures. So the main structures, so like seminiferous tubules to the rete testes to the epididymis, but we'll skip some of these. So there is going to be a couple of ordering questions. What structures do these pass through? These are the seminal. So we have a lobule, and remember there are about 250 of these in each testis. And then each lobule is going to have 1 to 4 seminiferous tubules. These are coiled, and this is where sperm is produced. As I mentioned, we will go through that pathway. Then they end up, so the majority of the seminiferous tubule is highly coiled, but at the very end, they end up with this straight tubule that feeds into this structure, is the rete testes. So you do need to know that sperm start off in the seminiferous tubules. Then they make their journey down this straight tubule to the rete testes. So the rete testes is kind of a collecting network here. And then from the rete testes, it will go into the epididymis. And the epididymis is also highly coiled, and they will go from the head down through the body and then into the tail for maturation and storage. From the tail of the epididymis, they are then going to be propelled through the vas deferens, and then we'll keep going in a little bit, okay? But for this part of lecture, sperm are produced in the seminiferous tubules. They will then go into the rete testes. From there, they'll go to the head of the epididymis, then to the tail of the epididymis. In order to mature, they'll spend about 20 days there. So they can spend months there too. And then up through the vas deferens. So for this slide, know that order. Okay. Once sperm are produced, then they need to mature. They'll do that maturation in the epididymis. Remember, the epididymis has the head, the body, and the tail. So maturation is primarily in the tail of the epididymis. It's a minimum of 20 days, but sperm can stay there for months. Sperm are ejaculated from the epididymis. Okay, that's the structure that will house the mature sperm, and then they're propelled through the duct system. So they're not stored anywhere other than the epididymis. The epididymis is the only structure that will store sperm. Okay. During ejaculation, the sperm will travel from the epididymis through the ductus deferens. So the ductus deferens is the preferred term now. When I was in school, it was the vas deferens, which I kind of like the term because this is the structure that's ligated during a vasectomy. So while ductus deferens is preferred, I think vas deferens makes a lot of sense too. The ductus deferens or vas deferens runs through the spermatic cord, and then it expands distally. So at the end, and we'll show you this pathway, to form something called the ampulla. The ejaculatory duct is the joining of the ductus deferens and the duct of the seminal vesicle. So the seminal vesicle, it looks kind of like a little, I don't know how to describe it, almost looks like a leafy structure, but it's almost like if a leaf met alveoli, because it's got lots of little bubbles in it, like facets in it. So those will join at the ejaculatory duct, and then we'll talk about accessory glands in just a second. And then there is the urethra, which is a common tube for urine and semen. And we'll talk about how the internal sphincter is closed so that we don't combine urine and semen, because urine is acidic and sperm need slightly alkaline. Okay. The urethra is in 3 sections: the prostatic urethra, the membranous urethra, and the spongy urethra. Males produce sperm in the testes, then it goes to the head, the body, and the tail. They'll spend about a month maturing, and then during ejaculation, it is propelled at like 15 miles an hour, 11 miles an hour, pretty fast. I think it's 11, through this vas deferens or ductus deferens that is going to come up originally through the spermatic cord, and then it branches off and kind of weaves its way back around into something. This is called the ampulla. So it feeds up and then back down and around, and this swelling is called the ampulla. So it's this pink one that's been cross-sectioned. Then we have the seminal gland, which produces the majority of seminal fluid. These combine at the ejaculatory duct, prostate gland, that is going to also contribute fluid, prostatic fluid, and then that all combines to come out the urethra. We'll talk about bulbourethral glands in just a second. The penis is the male copulatory organ. It is made, so there's the external genitalia of the male reproductive system is considered to be the scrotum and the penis. The penis consists of an enlarged tip called the glans and foreskin, which is a loose covering of the glands. If a male is circumcised, this is the structure that is removed. Internally, there are 3 compartments. There is a singular corpus spongiosum. It's going to surround the urethra and expand to form the glands. There are also the corpora cavernosa, which are paired dorsal erectile tissue. Okay, so on a cross section, this is the corpus spongiosum. And so this is called the spongy urethra because it runs through that corpus spongiosum. And then there are these 2 sections of corpora cavernosa. These are the ones that are more sensitive to nitric oxide. There will be some enlargement in the corpus spongiosum as well, but the main accumulation of blood is in the corpora cavernosa. It's more sensitive to nitric oxide. We'll talk about that in a few slides as well. As I mentioned, there are very important accessory structures. So there's going to be 3 main contributions to semen. The first is, of course, sperm, right? And volume-wise, it's very small, but there will be 100 to 300 million sperm per mil. Seminal glands, also known as seminal vesicles. So seminal glands are cells in the seminal vesicles. They produce an alkaline fluid. And it is 70% of the volume. And this is important because when we talk about the prostatic fluid, it's slightly acidic and we need an alkaline environment. So by the seminal vesicles producing a larger amount of alkaline fluid, that's going to give semen an alkaline pH, which is important in neutralizing the acidic pH of the female. So seminal vesicles produce a viscous, so thick alkaline fluid. It's going to contain fructose. Fructose is important for sperm motility. So the flagella is going to need ATP. And so there will be ATP also in semen, but fructose as well. Citric acid actually has a dual role. It has a buffering component, but then it also is it's involved in liquefaction. So semen at first is coagulated and then it liquefies. It's involved in both of those. A coagulating enzyme, and then prostaglandins. And prostaglandins are going to be important because they stimulate what's called reverse peristalsis of the uterus. So they'll cause smooth muscle contraction that help move the sperm up the reproductive system. There's a yellow pigment that fluoresces with UV light. And then, so that's about it. So in this chapter, there isn't as much material. So the material that is here, you kind of do need to know most of it. So you should be able to identify the components that are in seminal fluid. It's alkaline, it contains fructose, it contains citric acid, coagulating enzyme, and prostaglandins. The bulbourethral glands are not really they don't really contribute to semen. They are activated prior to ejaculation. So their purpose is to lubricate. Okay, so it is a clear mucus, but it is a lubricant. It also is going to, it gets released first, and so it will neutralize any acidic urine that is left in the urethra. The mucus, the lubricating mucus of the bulbourethral glands will be secreted first. The prostate, it encircles the urethra. It's inferior to the bladder. It's about the size of a peach pit. It secretes a milky, slightly acidic fluid. So this is why it's important that it is only going to be 30% of semen volume and not the 70, because we need it to be more alkaline than acidic. Prostate fluid contains citrate, enzymes, and PSA. So PSA is also a liquefier, and it is, I'm not quite sure how it got its name of antigen, but it is prostate-specific antigen. It is the component that is measured in men, I think, starting at 45 or 50. It can indicate prostate cancer. However, there is an extremely high false positive rate. So it's not considered a great diagnostic tool, but it's a blood test, so it's still widely used. Prostatic fluid plays a role in sperm activation. It makes up 30% of semen volume. So prostatic fluid is slightly acidic, makes up 30% of semen volume, and contains citrate, enzymes, and PSA. Okay, so it's gonna, and these enzymes play a role in sperm activation. Prostate cancer is the third most common cause of cancer death in males. It affects 1 in 6, but there's also benign hyperplastic prostate disease or main disorder, where there's just overgrowth of the prostate and it's not cancerous, but it can cause like UTIs because it compresses the urethra. And then prostate cancer comes in many versions, from very mild, non-aggressive to metastatic that will invade nearby bones. So wide variety. Fortunately, like with most cancers, the least aggressive is the most common. And that's how most cancers run. The last extra credit will open, I can't remember if it's already open, or I think it opens today, but anyway, if not, it opens soon. And unfortunately, we don't have enough time to really go into all of the reproductive diseases or disorders, so I think this will actually be a really interesting discussion section to read, because I think some of you will probably pick prostate cancer or breast cancer, and then there's a whole host of STIs that can be discussed as well. So it'll be hopefully a good read, right? Okay. Moving on to semen. Okay, so semen is going to have 3 major components. The first major component is sperm. Okay, so it is going to come from the tail of the epididymis and then get propelled through that ductus deferens. Sperm is volume-wise very small, but it contains roughly 100 million per mil, so roughly 300 million sperm at a time are ejaculated. There will also be some fructose in that ejaculate from the epididymis, and this will be used for ATP and to protect and activate sperm movement. Overall, semen is going to be alkaline, and this is going to neutralize the acidity of the male urethra that's really done by those bulbourethral glands beforehand. And then the female vagina is acidic because it's antibacterial, and it will enhance motility. Okay, so 3 components. Sperm is the first major component. And then, oh, okay. So I thought I had another slide that has, so it's semen and then is comprised of sperm, seminal fluid, and prostatic fluid. So those are the three sources. They will contain ATP, citrate, fructose, enzymes. So what we've already discussed, as well as we talked about how the seminal vesicles will produce prostaglandins, and that will be used to decrease viscosity of the cervical mucus, but also to stimulate reverse peristalsis. Semen also contains the hormone relaxin and other enzymes that enhance sperm motility, contains ATP for energy, fructose, which was on the previous slide, and some antibiotics, some coagulating factors, which are going to coagulate the semen initially, and then we have fibrinolysin, which will liquefy it. Okay, so coagulate first and then liquefy so sperm can finish the journey. Okay, so know the three major contributors: sperm from the epididymis, seminal fluid from the seminal vesicles, prostatic fluid from the prostate, as well as general components that you would find in semen. Onto the physiology. So now we're going to look at erection and ejaculation. So in order to deliver sperm, the penis needs to be erect. And so this is going to be due to the parasympathetic neurons, okay? So definitely know, oh, my star's looking weird, that erection is under parasympathetic control. Ejaculation will be under sympathetic control. Again, this is one of the very, very few times that the parasympathetic and the sympathetic divisions of the autonomic nervous system work together. They're synergistic. Normally, the arterioles that feed into that corpus cavernosum are somewhat constricted, okay? And then sexual excitement will cause activation of parasympathetic neurons to release nitric oxide. Nitric oxide is a potent vasodilator. You remember from blood vessels, it was that local control mechanism. So parasympathetic neurons cause local release of nitric oxide, which relaxes the vascular smooth muscle, and the arterioles dilate. Okay, so parasympathetic neurons stimulate nitric oxide release. Nitric oxide is a potent vasodilator. And then the corpus cavernosa is very sensitive to nitric oxide and will expand due to engorgement of the erectile tissues, filling with blood, resulting in enlargement and stiffening of the penis. Now, when the penis enlarges, one of the things that happens is that the drainage veins get compressed. And so that prevents the blood from flowing out as fast as it's flowing in, and that will maintain the engorgement. As I mentioned, the corpus spongiosum is not as sensitive to nitric oxide, so it is not going to be as affected, and it will keep the urethra open. So we don't want it to be sensitive to nitric oxide, because that would just close the whole system down, and that wouldn't be effective. Erection, parasympathetic control, parasympathetic neurons cause release of nitric oxide. Nitric oxide is a potent vasodilator, and then that is going to affect the corpus cavernosa because the arterioles dilate and the venules get compressed. So we have blood flowing in, it cannot leave at a very fast rate, and that's going to maintain that erection. So now we're on to ejaculation. So ejaculation is propulsion of semen from the male duct system. It is controlled by sympathetic nerves. Ejaculation is under sympathetic nervous activity control. The ductus deferens, prostate, and seminal glands will contract and empty their contents into the prostatic urethra. When there is central nervous system activity, sympathetic nervous system gets activated. It sends neurons to the ductus deferens, which is a very thick muscular tube. The ductus deferens is, like I said, it's very, very thick. The prostate is a fairly large gland, and then the seminal glands also have muscle innervation. The muscle layers are all going to contract on the glandular cells. So we've got glandular cells in the epithelium, and we've got some muscle around that, and those contract. The seminal glands and the ductus deferens empty into the ejaculatory duct. It's a conduit, okay? Then the ejaculatory duct flows into the prostatic urethra. The prostate dumps its contents also into the prostatic urethra, and that's the initial event. The internal sphincter of the bladder is going to constrict, preventing expulsion of urine or reflux of semen into the bladder. But then the presence of semen in the urethra triggers a spinal reflex. So we have our first event where we have sympathetic nerves stimulate these three structures to contract, and that empties their contents into the prostatic urethra. The presence of semen in the urethra then triggers a spinal reflex, and that spinal reflex goes to the bulbospongiosus muscles to undergo a series of contractions that cause the expulsion of semen. Okay, so it's a kind of a two event. Getting the semen together into the prostatic urethra is that first event. And then the spinal reflex to the bulbospongiosus muscles to cause expulsion of semen, that's the second event. So there's two events, but both are under sympathetic nervous activity. As I mentioned, we're going to talk about the 4 cell types that are in the seminiferous tubules. There are, okay, so these are the seminiferous tubules, are this layer here. Okay. Within the seminiferous tubules, there are 2 cell types that are directly involved in producing sperm. So the spermatogenic cells are the ones that are actually going to divide and produce sperm. However, they cannot accomplish this without the cystinocytes, which used to be called Sertoli cells, which is a lot easier to say. So the Sertoli cells are the cystinocytes, which is giving them sustenance. So I get the renaming, but a lot harder to say, are these supporting cells. And the Sertoli cells, they are going to, they're kind of like astrocytes with neurons. They're housekeeping and caretaking cells they're going to secrete something called antigen binding protein, which binds testosterone to give the spermatogenic cells the testosterone that they need for spermatogenesis. So they provide that, but they also provide nutrients. They take away waste. Without an adequate population of Sertoli cells, the spermatogenic cells will not produce sperm. So they're kind of equally important, at least in my mind. Then there are also myoid cells. These are smooth muscle-like cells that surround the seminiferous tubules to contract and squeeze the sperm and testicular fluid through the tubules, as well as interstitial or Leydig cells that are going to produce androgens. So they produce testosterone and some estrogen. And then this testosterone is going to, in the presence of ABP, maintain those very high testosterone concentrations in the seminiferous tubules. So there will definitely be an exam question or two on the 4 types of cells in the seminiferous tubules and what they do. And this is just a slide illustrating and reminding us how important these sustentotized sites or the Sertoli cells are. They provide the nutrients and the signals to those dividing cells, to the spermatogenic cells. They are going to help move spermatocytes and spermatids along to the lumen. They secrete testicular fluid, which is rich in androgens and metabolic acid, into the lumen for sperm support. They will phagocytize faulty germ cells and excess cytoplasm. And then interestingly, they form a blood testis barrier. So sperm are not formed until puberty. So we do have these spermatogenic cells, but they haven't produced sperm. And so sperm is not recognized as self. So it's actually kept from the immune system by these Sertoli cells. Okay, on to spermatogenesis, and then we'll talk about the maturing of sperm. Spermatogenesis is the process of forming male gametes. It occurs in the seminiferous tubules. It begins about at puberty, around 14 years of age. But the hormone levels and production, it actually takes about 3 years to stabilize. So it's a long process. Adult males make up to about 90 million sperm per day, and then once this all gets stabilized, males can make sperm until 70 years old. So the quality of sperm declines, but the sperm production continues pretty much throughout life. Spermatogenesis takes 64 to 72 days if conditions are hospitable, so about 2 months. When sperm are produced, they are unable to swim, but the pressure of this testicular fluid, and that's why we have those myoid cells, as well as the cystinocytes, push immotile sperm into the epididymis, where they are going to mature, gain motility, and fertilizing power. They get this acrosome. So spermatogenesis starts with when males are born, they have spermatogonia along the edge. So this is a seminiferous tubule, and the spermatogonium are going to be here kind of at the edge. Then once puberty is initiated, the first event is actually mitosis, because so this is the original cell. And the original cell is going to form 2 daughter cells. So daughter cell A is going to stay and remain essentially a spermatogonia, a stem cell. And then second daughter cell B, is the one that is going to go on and form gametes. Okay. If we didn't have mitosis, then if the original spermatogonia underwent meiosis straight off, we would lose this population. And with making, so women, we have like, I don't know how many eggs we mature through our lifetime, but it's like less than 500, I think. Compared to males, 90 million a day. So males cannot lose the starting material. So the first event in males is mitosis, because one daughter cell is going to remain as part of the germline, that spermatogonia, and then the second daughter cell is then going to go on and enter meiosis. So when the second daughter cell enters meiosis, spermatocytes form secondary spermatocytes, which form spermatids. Okay, so mitosis followed by meiosis 1, followed by meiosis 2. So then completes meiosis 1, completes meiosis 2, and it is going to then, these form spermatids. This process, once it's initiated, just keeps going. And this is going to be something that is different in the female reproductive system, where we arrest oocytes at different points in meiosis. Okay, so male gamete production, much more straightforward, except for you have to remember that that first event is mitosis, so that we always maintain spermatogonia, a germ cell in the available. Then daughter cell B continues through meiosis 1, meiosis 2, ending in spermatids. Spermatids are non-motile. In spermiogenesis, spermatids become sperm. Keep straight that we have spermatogenesis, where we're going to get spermatids. And these are going to be non-motile. The first event is mitosis of the spermatogonia. One stays as a stem cell, one continues on through meiosis 1, through meiosis 2, and produces 4 haploid non-motile spermatids. Then we have another process called spermiogenesis, where spermatids are going to mature and become sperm. So know the difference between those two terms. Spermato, you're going to end with spermatids. Spermio, you're going to end with sperm. This is spermiogenesis, the transformation of a spermatid from spermatogenesis into a functional sperm. So the definition of spermiogenesis is transformation of a spermatid into a functional sperm. The spermatid needs to elongate because it's not long enough, and it needs to shed its excess cytoplasm. So it's not going to carry any extra volume or weight that it doesn't need. And then it forms a flagella, a tail. So this acrosome is going to be important in penetrating an oocyte. And then we have mitochondria, which are going to use that fructose and the ATP that are in this fluid to turn the motor proteins for the flagella. Okay, so now we're going to look at hormonal regulation of testicular function. Like most things that we've been looking at, the hypothalamus is going to be at the top of that axis. So we have the hypothalamus regulates the anterior pituitary, which then regulates the testes. Okay. So the first step, so again, you might see that this is going to potentially be an ordering question. The hypothalamus releases gonadotropin releasing hormone, GnRH. Okay, so this is a stimulating hormone. It then causes the anterior pituitary to release its gonadotropins, FSH and LH, which are named for their functions in the female reproductive system, but they have functions in the male reproductive system as well. FSH is follicle stimulating hormone, and follicle stimulating hormone is going to directly affect spermatogenesis. It causes cystinocytes to release ABP, so androgen binding protein. This makes the testosterone levels high. So FSH, follicle stimulating hormone, is going to directly affect spermatogenesis. Then we have LH is going to affect the Leydig cells. Okay, so luteinizing hormone is going to increase testosterone production by the interstitial Leydig cells. FSH affects the cystinocytes or the Sertoli cells to produce androgen binding protein to keep this testosterone level high, which stimulates spermatogenesis. Negative, we can skip that one. Negative feedback from testosterone then is going to inhibit the hypothalamus, as well as a hormone called inhibin, which is also produced by the Sertoli cells, which feeds back to the anterior pituitary, inhibiting FSH release. So hypothalamus produces stimulating gonadotropin releasing hormone, which tells the anterior pituitary to release FSH and LH. FSH affects the cystinocytes or the Sertoli cells to produce or release androgen binding protein that creates a high testosterone environment for the spermatogonia, which is stimulates them to start that mitosis, then meiosis 1 and meiosis 2 process to produce spermatids. LH is going to affect those interstitial cells of Leydig to produce testosterone. And then we have a negative feedback system to both the anterior pituitary and the hypothalamus. So I would recommend spending some time. I know it's a lot of words, it's a lot of hormones, but I think if you draw this out yourself, that will be helpful because there will be a couple of questions on this one as well. Oops, sorry about that. So this says in words what I just told you, sequence of regulatory events is hypothalamus releases gonadotropin releasing hormone, GnRH. That is going to stimulate the anterior pituitary to produce FSH and LH. FSH then stimulates the cystinocytes to release ABP, which keeps the concentration of testosterone high, which stimulates spermatogonia or spermatogenic cells to enter into spermatogenesis, mitosis, meiosis 1, meiosis 2 to produce spermatids. At the same time, LH is binding to those interstitial cells of Leydig to secrete testosterone. Rising testosterone levels also triggers spermatogenesis. This is the one that won't be in the ordering, just the secondary sex characteristic effects of testosterone. Rising testosterone feeds back onto the hypothalamus. This is a negative feedback system. And then inhibin is also going to negatively affect, have negative feedback to the anterior pituitary. So we have negative feedback to both the hypothalamus and the anterior pituitary. So these are probably going to get lumped in together. So do know that pathway, that ordering of regulation of the male reproductive system. This is looking at plasma testosterone levels and sperm production versus age. So testosterone has this kind of biphasic. This spurt here is before birth. Okay, so as a fetus, in order for the male genitalia to develop in a fetus, there needs to be a high level of testosterone present. And this part has been taken out, like the determining of gender in a fetus has been taken out of your textbook, or at least I didn't see it. And so I didn't put it in the slide. I find it really interesting though, so I might put a little video at the end of the female reproductive lecture, just because it's interesting. Okay, so there's this large peak of testosterone for development of male genitalia in the fetus. Then it goes back down. There's a little peak here, but then it goes back down to very low levels, which start to increase at about 10, 11. And like I said, these levels take about 3 years to stabilize. So the onset of puberty is supposedly about 14. I'm sure there's quite a range. And then, but it doesn't really stabilize till about 17. So it's kind of this period of prolonged puberty. And then in the adult, male testosterone and sperm production stays pretty high until 65, 70 years of age, and then begins to taper off. Testosterone levels can start to decline as early as 50. So sometimes this is shifted a little bit. And there's a whole other discussion on pollutants in the environment and hormone levels in both males and females that we won't have time to go into, but you guys might find that in if you want to add that into your discussion section. Testosterone, like all steroid hormones, is synthesized from cholesterol. At puberty, it will initiate spermatogenesis. It's going to mature the accessory ducts and glands. It is responsible for male secondary sex characteristics such as pubic, axillary, and facial hair, deepening of the voice because the thickening of the vocal cords, increase in bone size and density, increase in muscle size and mass, as well as epiphyseal plate closure. It is responsible for activating sex drive, and the prostate will need to convert testosterone to dihydrotestosterone to use it. The brain actually converts testosterone to estradiol, so to an estrogen derivative for some of its effects. Okay, so that's it for the male reproductive system. We have 15 minutes left, so I'm going to run through STIs real quick, just because that'll leave us otherwise the next one runs really long. So, okay. I think it's only 4 slides. Okay, So part 5, sexually transmitted infections. STIs are very common, especially in the United States. The United States has the highest rate of STIs in any developed country. So lots and lots of STIs in this country. Most of them are pretty easily treated. Some of them are not. But so we'll run through, we'll look at a few bacterial and parasitic STIs, then we'll end with viral. And your book doesn't do AIDS. I guess it's in the main chapter, which we aren't going to get to. So that's why that one's not in this list. So, okay, so we'll start off with bacterial and parasitic STIs. There will be some questions like matching what is the disease in its vector, or if there is something unique about it, like being the most common bacterial STI. So for bacterial, we're going to talk about like chlamydia and gonorrhea. For chlamydia, it is caused by the bacteria Chlamydia trachomatis. It is the most common bacterial STI in the United States. It's responsible for about half of all diagnosed cases of pelvic inflammatory disorder, PID. Symptoms, discharge, pain, painful intercourse, and it can affect periods, especially if it's associated with PID. The good news is it is treated by tetracycline. Trichomoniasis is a parasitic infection. 70%, it affects more women than, I don't think it is, than men. And then it is 70% of women have no symptoms. 30% would have a vaginal discharge. So, and again, this is easily treated. Parasites are usually pretty easily treated because they don't share a lot of physiology with our bodies, and they don't become, they're not so prevalent that they've built up a resistance to our drugs. So most parasites are pretty easy to treat. Okay, gonorrhea is also a fairly common bacterial STI. It is due to the bacteria Neisseria gonorrhea. It is an infection of the reproductive and urinary tracts. Most infections are asymptomatic, and that's why we have so many STIs in this country, is because so many of them are asymptomatic in the majority of people who have them, so they don't know that they have them and they pass them along. Males, painful urination, discharge of pus. Females, PID, uterine bleeding, vaginal discharge, abdominal discomfort, and if untreated, it can lead to sterility. Unfortunately, gonorrhea, it's been around a long time, and so it has developed antibiotic resistance, and so now treatment with at least 2 antibiotics is recommended. Syphilis is due to the bacteria Treponema pallidum. It is transmitted sexually, but it can also be transmitted mother to fetus. And gonorrhea also affects the fetus if the mother is pregnant. So it's one thing to also get checked for, I guess, if there are symptoms. And the infected fetus can be stillborn or die shortly after birth. For syphilis, infection is asymptomatic for the first few weeks. Then a canker appears at the site of infection, but then that disappears. If that individual does not realize that the canker is present, then secondary signs can appear weeks later, resulting in rash, fever, and joint pain. So syphilis can actually lead to arthritis if left untreated. It can enter a latent period, which may or may not progress to tertiary syphilis. Tertiary syphilis is life-altering, and that it will cause lesions to develop in the central nervous system. So it does end up affecting the brain, blood vessels, bones, and skin. But the treatment is penicillin. Okay. moving on to viruses. Like I said, HIV is under the, I'm assuming it's under the main chapter, so it's not, I didn't cover it. But there's HPV and genital herpes. Both of these are very, very prevalent in the United States, well, United States and worldwide. Over 50% of adults are infected with human papilloma virus over their lifetime. Many of them go, like, they are cleared and people don't even know that they've been infected. It's a group of 40 or more viruses, and some of these strains can cause genital warts, and then 80% of cases of invasive cervical cancer can be linked to HPV. HPV, this family of viruses is also associated with an increased risk of penile, anal, and oropharyngeal cancers. So the presence of HPV increases cancer risk of reproductive systems. Genital herpes is from the herpes simplex virus. So this is another family of viruses. They're difficult to control because most people do not know that they are infected. Only 15% display signs of infection, characterized by latent periods with flare-ups of vesicles. Again, it can be passed on to the fetus. Treatment is with antiviral drugs for herpes, but I'm not aware of one for HPV. So the main thing with STIs is, especially for women of childbearing age, don't get offended if your physician wants to check for STIs. They're just doing it because so many of them can cause miscarriages, stillbirths, or disease in the baby. So it's pretty common now to just screen everyone for STIs at prenatal visits. Okay, so that's it for male reproductive system and STIs. Our next lecture is on the female reproductive system.